So I'm going to briefly talk about oncology in PICU, and since it's just us, and Sunil, please just stop if there is any confusion or anything that you would like to.
Yeah, sure.
Yeah. So I think just to put it in context and set the scene, it's useful to know that the outcomes from cancers in children have hugely improved. And the overall mortality is less than 6%. So that's good news. And of course, although I have said better PICU care, probably is more better oncology care in terms of the treatment regimes and how we are aggressively looking and trying to treat for possible complications. And of course, what is important when it comes to cancer is the primary cancer, the complications related to therapy, and the long-term side effects. But what's still important and very useful for us to know as intensive care is that nearly 40% of these children would require PICU through some part of their journey in the cancer treatment. And they only make about 10% or less of PICU admissions. This is the PICUnet data, if you look at the national database. So that's PICUnet, Rachel and Natalie, you may not be aware of. So PICUnet is essentially a national, so it's Pediatric Intensive Care Audit Network, just like ICNAC or TAN collects trauma. And PICUnet collects information about every PICU admission from all the PICUs and the retrieval teams. And there are basic minimum data sets. And that's a very useful data collection for us to be benchmarked against each other and also know exactly what is happening nationally. So we have year-on-year reports published, and they tell us exactly what age group, what sex, what diagnosis, what therapies, etc., what their mortalities are, and then they give us the charts to tell us how we stand in comparison to the other PICUs in the country in terms of the sickness severity. So we do the PIM3 scoring now. So we collect their admission parameters, and that gives us an objective scoring in terms of their survival and probability of death. And that is then used to benchmark every single PICU or the retrieval service. So as per that data, it's nearly less than just about 10% PICU admissions. But of course, although the overall mortality is low, the treatment-related burdens from cancer therapy are still quite high, and roughly about 16% 5-year mortality is what we're looking at. Infectious complications, probably the commonest, and commonest with hematological malignancies, mainly leukemia. Also, the leukemia is the most common pediatric cancer that we see. If they come with septic shock, the mortality, depending on what study you look at, can range from 8 to 40%. And they do have a higher risk of developing multi-organ dysfunction because of course, the underlying cancer and the treatment that they get. And they're immunocompromised with whatever treatment regime they are on. So the multi-organ dysfunction is common. So nearly in 60% of those will come with septic shock. So this is some data which was published in 2019 from this group, which is the PICU Oncology Kids in Europe Research Group. It's a part of the European Society of Pediatric and Neonatal Intensive Care. And they did a systematic review and meta-analysis of close to 17,000 children from various publications. And they identified that the pooled mortality, and these are the patients who were admitted to pediatric intensive care, so going away from the overall mortality figures. So out of those cancer children who would be admitted to pediatric intensive care, their pooled mortality from all the publications till that point was nearly 1/3. So that's quite high. Do bear it in mind in the context of overall PICU mortality, which is less than 4% in UK. 30% of these would require mechanical ventilation, 40% would require inotropes, and roughly about 5% required renal replacement therapy. And these are some of the plots that they created in terms of the overall outcome. So the top one is the mortality figure, and clearly there is a slight decrease over the years. And this is the mortality in relation to the septic shock, which is again slowly and gradually improving. And if we try to dig deeper into this patient population. And although this is a slightly old paper from 2014, again, a systemic review of what kind of cancers would present and what kind of mortalities they would have. So, of course, better outcomes if you have a solid cancer in comparison to hematological malignancies. We're specifically looking at PICU mortality, right? And the PRISM-3 is one of the scoring methods we would use for severity of illness in pediatric intensive care. So, for example, in the adults, we would use so far Apache scoring. In pediatrics, it's either PRISM or PIM. So PRISM is primarily, so it's pediatric risk index of mortality, standardized mortalities. It's mainly a score that is used in US. And PIM is what we use in UK. Very similar scoring systems which take into account the physiological state of the child on admission or within the first 24 hours, some lab parameters, and then some background issues. So what their admission diagnosis was. Clearly, when we're looking at hematological malignancies, the odds ratio of mortality is much greater, of course, if you're more severely ill. So myeloid leukemia, much worse outcomes. And those who are post-bone marrow transplant, for obvious reasons, have a much greater risk of dying if they end up in intensive care, or of course, if they have an infection. And then trying to break this data further in terms of the type of infection. So bear in mind these are the purple and the red bars are those who've had bone marrow transplant. Purple for hematological malignancies, and the red for solid cancers, right? So the mortality is greatest in those groups who've had bone marrow transplant. And very obvious, I mean, I don't need to define exactly why that would be. For whatever reason, if you've had a bone marrow transplant, you're at greater risk of dying. Fungal and viral, although are less common, but they clearly define either the prolonged immunosuppressed state or a severely immunosuppressed state. So viral infections that we would commonly see in these immunocompromised children have a much greater likelihood of them dying than compared to the bacterial infections, which actually the bacterial infections are more common. So it's sort of trying to split. So if you look at the overall mortality with infection, it'll still be greater with bacterial because we see more bacterial infections more frequently. Gram-negative, majority of the times it would come from the gut, sometimes from the chest. So there's bacterial translocation, given that they have mucosal breakdown and the barrier function is not that great. Gram-positive because they've got lines and catheters, so Hickman lines, VP shunts, any other catheters, etc. So that's how they look at. And then if we look at the PICU mortality by intervention time, of course, the more number of organ support you're using and more invasive you get, the higher the propensity of death, which actually applies to the entire cohort of our patient population. So non-invasive ventilation, better, invasive, certainly worse because you're adding another organ support, not just that, then the likelihood of them developing ventilator-associated pneumonia or complications related to that increase, and renal replacement, even go further. And this is actually from the previous study, which defines the odds ratio of death in relation to mechanical ventilation, inotropic support, and CRRT. So just a bit more objective marker of that. This is what is from the east of England. So these are this is the data that I found on OnCallNet, which actually now I was trying to update it with more latest figures, but I couldn't find anything. So this is the annual report that they generate here in east of England. And actually encouraging to see, so the blue at the top are the ALL, which is the commonest cancer, and the orange is the brain tumor. So that's the biggest, second biggest kind of oncological diagnosis that we would have in pediatrics, and rest of them. So if you look at it year on year, the numbers have actually not changed massively and have remained pretty much static. And if we look at the disease patterns of death, well, 41%. So brain tumors do make the biggest group of children who would die, followed by leukemia and myelodysplasia, and then everything else that comes around it. And when you look at the cause of death, so these are real actual figures from east of England. it's very, very useful to know that majority of deaths happen because of progressive primary disease or relapse of the cancer, and less in relation to the complications related to the treatment, which is sepsis or the bone marrow transplant complications. And that clearly shows that we have come a long way in terms of how we manage these children and minimizing what is treatable or what is preventable. Clearly, there is further way along to decide what kind of treatments or whether they can, they're constantly working on that. So there is every child who presents with cancer is a part of a research study. So they're trying to collect as much data and trying to improve on their induction and maintenance regimes, etc. But that's beyond what I'm going to talk about. That's not my field. But this is how these figures were till 2017, and unfortunately, I couldn't find more latest figures. Maybe I'll ask the oncology team. So they are another specialty where they look at their numbers and how they're performing very, very carefully, just like us in intensive care team. And this again is from a 2012 paper in trying to define an algorithm for which patients should have pediatric intensive care. And that's always a very, very important question, because if you keep this in mind, right? We're talking about progressive primary and the relapses causing majority of deaths. So whether or not every sick oncology child should be subjected to full pediatric intensive care, something that needs to be taken in context of how good or bad their cancer prognosis is, what stage of treatment they are in, whether it's a relapsed cancer, whether they've had bone marrow transplant, etc. And although we may not directly follow it, majority of our patient cohort with cancer diagnosis is patients who are admitted after a surgery. So some of them are brain tumors, some of them post-Hickman line. So more HDU rather than actual intensive care patients. And then post-op, yes, of course, they get early admission, full support, and then medical complications. Then depending on where they sit in terms of their oncological prognosis, we give them a PICU trial, and whether or not they improve would then justify going further or thinking about palliation. Interestingly, the PEDS oncology team also have what they call as a parallel planning for palliation, especially if it is a high-grade tumor. So they start talking about it much earlier, to start thinking about if the patient does not respond to treatment, how far would we push it? So they keep that in mind from early on. And as I said, the reasons for admission to PICU majority are post-op care. And then when you look at medical reasons, the respiratory is the commonest. So either a chest infection or any kind of other complication related to therapy, or an airway compression, which is probably not that common in terms of what we see. So respiratory and sepsis are the two commonest medical reasons for children to be admitted, and then followed by neurological problems, renal dysfunction, and tumor lysis. So we become much better and very good in terms of preventing tumor lysis with the different treatment regimes. And this is reflected in this pie chart. So 45% admissions due to respiratory failure, 30% sepsis and septic shock, and then 15% neurological problems and 10% with renal dysfunction. I'm sure you would have, depending on how long you spend here, in a year, you'd probably see all of these in the patients that we would admit. So what's worth knowing when we're admitting these children? Well, what kind of oncological diagnosis they have, what stage they are at, whether they are in induction or maintenance phase, whether they've had radiotherapy, whether this is a relapsed patient, whether they're post-bone marrow, what is the degree of disease severity and its distribution, whether or not it's metastasized already. We, of course, know, the oncology team would be already involved. It has never happened that we've admitted a child that the oncology team is not aware of. So we work very closely with them. We know what they can offer and not, and they're very switched on in terms of when they're seeking support from outside teams. When, for example, that little child we had with the liver tumor. And then, of course, some degree of familiarity with the approved policies and protocols for the treatment, as well as when we are offering them HDU care. So, for example, we would admit a lot of these children for hyperhydration, especially if their leukocyte counts are above a certain number because they are at a higher risk of tumor lysis, or we would admit all tumor debulks. So any child with brain tumor who undergoes craniotomy for tumor debulk would come to PICU, to HTU for 12 to 24 hours, watch, etc. What the expected complications are from treatment, whether they are already in palliation and what we are offering them, it always forms an important part of the discussions early on. And then, of course, the emergencies and life-threatening complications. So I wanted to start with infections, because as I said, this is probably the commonest complication seen in these children. Well, bacterial is the commonest, and they've managed to reduce the incidence of sepsis and septic shock in children who'd actually end up with us by very aggressive empirical treatment for fever. And I'll show you how they treat it. And then looking for where the infection might be and controlling the source. So that happens without our involvement on the ward or sometimes in community setting. The septicemia risks are greatest from skin and gut flora. If they get gram-negative infection, it can be fulminant. Fungal, of course, viral, opportunistic, and fungal. This is the patient group which is most susceptible to these because of prolonged antibacterials and myelosuppression that they would have. Fungal particularly, you would see some deep-seated infections, and we sometimes do look quite aggressively with scans, doing abdominal scans, head scans, chest scans, because they're not the easiest to diagnose. And then viral and opportunistic, again, because of prolonged immunosuppression. The commonest seen would be CMV, VZV, reactivation, and sometimes pneumocystis. And they do use prophylaxis both for fungus and viral infection, mainly for the herpes group, as and when required. So why are they at increased risk of infection? Well, we do know it intuitively, but if we try to objectively define, they have a problem with each of these arms. So innate immunity, adaptive immunity, and the barriers, which are the three ways our body tries to reduce our infection risk. Decreased barrier, probably the biggest contributor, because they are at an increased risk of developing mucositis. They have skin breakdown, they have prolonged hospitalizations, their nutritional status may or may not be appropriate, and all that contributes to reduced immunity to fight infections, and of course the indwelling catheters. The innate immunity, because they would have neutropenia related to the therapies that they're getting, because we're using such toxic drugs. And then the qualitative function of not just the numbers, the qualitative function is also affected because of the use of steroids and radiation. Similarly, the adaptive immunity, so they will have lymphopenia in addition to neutropenia, and then altered humoral and cell-mediated responses. It's important to know that the diagnostic criteria for sepsis are not different to non-immunocompromised patients. So we use the same diagnostic criteria, which are fever, hypothermia, tachycardia, and tachypnea. And then we look for organ dysfunction, mainly hypoperfusion, acidosis, and hypertension, which are clearly the late signs, and we try to pick it up earlier. The common etiologies, as I said, the bacterial are the commonest. In gram-positive cocci, you would see some kind of a skin bug, so staph epidermidis, sometimes staph aureus as well, and then gram-negative rods. So Enterococcus E. coli, usually the gut bacteria, and occasionally you'll see Pseudomonas as well. Candida is the commonest fungus you will see in these children. And then chest infections are, again, very common, bacterial more than any of the others, and the commonest etiology are strep or staph, followed by Pseudomonas, Klebsiella, and E. coli. And then, of course, you would also have an odd patient who'll have pneumocystis. Sometimes they'll get prophylactic Septrin for that, and we do try to look quite aggressively for any kind of infection. And this is just for us to be aware. I mean, we haven't yet started using CAR T-cell here in Cambridge, but this is the next thing that will happen in near future. So CAR T-cell is chimeric antigen receptor T-cell therapy. And it's a relatively new thing, which was approved for use in UK about 5 years back. And majority of our children are still going to UCL to have that done. And it's kind of, it's an immunotherapy. And the way it works is you take out the patient's T cells, then give them chemotherapy to kill the cancer cells to a certain extent. And then you make a chimeric form of the T cell by using some or the other kind of an immune molecule. And then you grow these chimeric T cells in the labs with the idea that T cells would not be able to identify cancer cells from normal cells otherwise, but with this chimeric immune molecule attached to them, they would then be transfused back into the patient and they would selectively attack the cancer cells. But clearly, because it's an immune modulation, it can cause severe inflammatory response and cytokine release syndrome. And if you look at the evidence of impact on the cancer treatment, well, it's kind of still mixed, but it's an approved therapy, it's an expensive therapy. They say that mice says that it has got relatively good prognosis when appropriately used. Mainly used for leukemia, which is not responding to their first-line chemotherapy. Also used in adults for lymphoma. Those are the two main things I have seen. I have never seen it being used, not looked after a patient where it was used. And they, because this is not actually an infection, but because there's a huge cytokine release when they infuse these chimeric cells back into the patient, they do have a SIRS kind of response. But if treated appropriately, that cytokine release has a much better outcome than what we would see with an infection-related cytokine release. So they are treated very aggressively with antihistamines, antibiotics, and fluids. And occasionally they would use immune modulation because it's mainly an IL-6 driven response. So they use the specific molecules, monoclonal antibodies against IL-6. But clearly something we will gain experience as and when it starts happening here in Cambridge. So the basic pathophysiology of sepsis is the same, really, as in an immune competent host. There's a local infection caused by bacteria, which then enters the bloodstream. Clearly, the propensity of this happening is greater because there is no way to localize that infection and it will spill over and cause sepsis because you don't have the immune system to fight the infection. And then following on from there, the cascade that we would see otherwise from SIRS to sepsis to severe sepsis and then septic shock. And the progression probably could be more rapid in immune compromised hosts than in immune competent hosts. And as I said earlier, the definitions used are the same as we would use in any other child who's immune competent. In the adult side, they have created this definition as a part of the sepsis 3 in neutropenic patients. And what's important for us to remember is that when they've had cancer treatment, there are certain markers which I would use bedside as a marker for severity of sepsis, which may or may not be applicable. So for example, thrombocytopenia in an immune competent child, for example, the one that we have right now, is clearly a marker of the severity of sepsis. But majority of post-chemotherapy children would have thrombocytopenia, and you cannot really say low platelet counts related to the severity of sepsis. So stuff like that we need to be aware of and be careful in terms of how we integrate the numbers. Equally, there, like, for example, when I talk about organ dysfunction, so sometimes we need to be aware whether they might have, for example, a neurological malignancy or a brain tumor that has been operated. They might have some deficits. They might have some specific drugs that could cause neurological abnormalities. So if a child is otherwise well and then is looking drowsy, I clearly know that the sepsis is bad and they're not getting enough perfusion or oxygenation to their brain. So it just needs to be put in context with what our patient has. Just remember that. So this is the East of England guideline in terms of the antifungal and antibacterial prophylaxis in patients with different kinds of tumors, different kind of phases of their tumor treatment. These are all available on Connect. So if you are interested in looking at it, you could look at that. And then they also, this is again our East of England format, is management of fever in an immunocompromised child. And then they are scored in terms of their risk for bacterial infection from a score of 0 to 3. And then depending on the risk stratification, they would either consider admitting this child or sending them home with safety netting advice. And when and where they will be admitted to the hospital for IV therapy, when they could be sent home onwards. So it's all very, very protocolized and very well defined. And that's why we see very few complications in terms of a severe septic shock in an otherwise oncology child coming to us. And then the first line usually when we are treating them is piptaz and gentamicin. That's what we would use if an oncology child is admitted. If we are worried about the Hickman line, clearly vancomycin gets added quite quickly. If we are worried about a VP shunt, which might be infected, we use meropenem and vancomycin as a combination. I think I understood from speaking with one of the teams, especially after our last patient, was that they were running some kind of a randomized control trial of prophylactic Cipro versus amoxicillin. And that's what they were worried about, whether it was a ciproflox related reaction in our last patient, which led to severe liver dysfunction. So it's an extremely rare complication, but it's a known complication. Again, over and above treating the infection, there is a very aggressive lookout for the source, and the source control is extremely important, even more important in an immune compromised host than it would be in an immune competent host. So we have extremely low thresholds to take out the shunts or the Hickman lines. We do have sometimes debates whether or not we try to treat a Hickman line infection by giving antibiotics. And that discussion happens mainly in children who have, this is their second or third Hickman line, and there is a clear issue with the access and whether we would run out and whether it would be useful to try and preserve it, and what would be the threshold to say, well, after we've tried and now it needs to come out. The patient's clearly not looking good. So empiric broad spectrum antibiotics, and of course an early consideration of antifungals, whether prophylactic or treatment, is common. We would give them the full PICU supportive care as we would for any other patient. But of course, always to look out and think about, because these children can have cardiac dysfunction. So we do look for an early echocardiogram in these children. So specifically if they've had high dose anthracycline or if they've undergone radiotherapy, because that can compromise their cardiac function. Given the fact that they've had steroids, more or less all of them, and they're at a high risk of HPA suppression. So early introduction of replacement steroids, especially if they're in septic shock, because they may not have enough capacity to produce that. And granulocyte transfusion, to be honest, I've never used. And this is an extreme therapy for children who have no granulocytes to fight the infection. And the idea is that you can infuse them something from outside, but a treatment which is fraught with its own complications and not an easy deal, so we don't use it. We do use GCSF to try and push their bone marrow. Although again, people question whether just the quantity is enough or whether they are qualitatively as effective in terms of their capacity to fight the infection as a normal neutrophil would be. So that was a brief about sepsis, and clearly this is the other extreme, hyperleukocytis. So this is probably what we see a lot of children with. They are mainly here for HDU care and rare children who would end up becoming a proper ICU patient. So hyperleukocytis, like cytosis, the white cell count greater than 100,000. And it is a measurement of tumor burden. Usually this is what they would find on admission. So when the patient's just been diagnosed with cancer. So some child presents to a DGH with fever, not settling, couple of bruises, plus minus something, not feeling well, etc. They did a blood count of 150, 200, and then they would see blasts in that situation on the peripheral spleen. So 5 to 20% of acute myeloid leukemia and 9 to 13% of acute lymphoid leukemia. So probably a little more in myeloid range than in the lymphoblastic leukemias. These would be the presentation for the cancer. And almost all of the chronic myeloid leukemia would have hyperphagocytosis. And why we're worried about them? Well, two things. Of course, the hyperviscosity, because the white cell count is so high. But the two, equally, that's the tumor burden. So the moment you start treating them, and sometimes without treating them spontaneously, they could go into hemolysis. So because it's a huge number of cells which will be killed very rapidly, and you're worried about electrolyte dysfunction as well as renal failure. And then also interestingly, I mean, when you look at, so the myeloid cells are much larger and less deformable. So the hyperviscosity is much worse with that than the lymphoblasts in the ALL setting. And the hyperviscosity, we do see sometimes the lungs very badly affected by that. And then them presenting with an ARDS with or without pulmonary hypertension kind of a picture, having hyperviscosity affecting the brain perfusion, and children presenting with seizures and some kind of neurological signs and symptoms. And majority of them would be treated with hyperhydration before they can be given chemotherapy. And the whole idea of hyperhydration is to keep the kidneys flushed so that whatever is spilling out from these tumor cells is getting flushed out of the kidneys. But that hydration volume also puts them at a risk of fluid overload and cardiac failure. So that's why they are watched in HDU, specifically when their white cell count is 100,000 or around about that mark. They will have their hyperhydration done here on PICU rather than being done on the ward. And the induction chemotherapy is usually given after that. So I've sort of briefly already talked about what happens with leukostasis. So there's increased blood viscosity, and then these can cause organ hypoxia, which can then in itself set a whole cascade of secondary events leading to DIC, etc., and tumor lysis syndrome. And how do we treat it? Well, hydration is probably the commonest treatment regime used, and usually about 3 liters per meter square a day is what they would use. And they tend to try and avoid giving diuretics so that there's like an adequate volume, and hopefully the hydration volume in itself would keep a decent amount of urine output going. Sorry, is it just working on its own? Maybe I need to do something to change that. What do I do? And just do this. Yeah. And then we do try to avoid giving them red cell transfusion. So the threshold for red cell transfusion and platelet counts is much lower when it comes to oncological children, because we tolerate a lower count and a lower hemoglobin in these patients. Seems to be an automated form for some reason. And that's mainly because you're trying to prevent hyperviscosity. So the red cell transfusion sometimes won't happen till about 5, hemoglobin of 5 or below. And in that case also we will use a tiny aliquot. So we'll not use the same aliquots we'll use for otherwise normal children, just to try and avoid and do it very gently. I'm just talking about oncology.
Oncology.
Yeah. And of course, like, we need to keep on top of their platelets, treat coagulopathy, specifically when it comes to myeloid leukemia, because that would reduce their risk to get intracranial hemorrhage. Urine alkalization, probably something we did in the past. I haven't used it in a long time. An exchange transfusion is very, very rare. We sometimes would use it specifically when it comes to trisomy 21. They sometimes present with neonatal leukemia, and that's a specific disease and they come with very high white cell count, and they have hyperviscosity. And the way to reduce the white cell count quicker is by using an exchange transfusion. But that's not very common practice for older children. And then, of course, supportive care, depending on how much waterlogged you have made them in terms of the extra water we are trying to give. And that's the tussle you will find Rory having with the oncology team in terms of how much fluid we will allow them to give.
But they hate us transfusion them at all.
Yeah, we do. Yeah. So tumor lysis syndrome. It seems to be going on.
Oh yeah, go further. Okay, thanks.
You okay?
Yeah,
Should I
I
keep-
just want Finley's medicines on health.
Okay, fine. So tumor lysis syndrome, of course, like, as I said, hyperleukocytosis in children with leukemia, in any other rapidly growing tumor like lymphoma or bulky disease, you could have, again, a very variable number when you look at different studies, anywhere ranging from 4 to 42%. In hematological malignancies, the mortality is quite high. So that's why they are very careful in terms of how they use the hydration, at what stage they institute chemotherapy, and how these children are monitored either on the ward or in HTU. The commonest are T-cell leukemia and lymphoma, followed by B-cell, and then Burkitt's lymphoma is probably quite high on the list of tumor lysis syndrome. And majority of the tumor lysis would happen at presentation, but sometimes it happens after starting chemotherapy. And very clearly the high risk of life-threatening electrolyte disturbances and renal failure. And those children who are already dehydrated or have some degree of acidosis or coexisting renal dysfunction, they are at a high risk of tumor lysis syndrome. We had a child a few years back who had a large neuroblastoma, intra-abdominal, and even before the chemotherapy was started, this child had external compression of the ureters and kidneys from the neuroblastoma. And there was a huge debate whether or not, and this child had some early signs of tumor lysis, and there was a huge debate whether this child should go to theater to release the obstruction by putting some ureteric stent, or whether they should have renal replacement therapy and electrolyte correction before they went to theater. So we do have to try and work out what would be the best and the safest solution in that situation. No, it won't move. And this is what happens basically. So either spontaneously or due to induction chemotherapy, the tumor cells would start breaking, and clearly a lot of material would pour out. And the major ones that we are worried about are potassium, phosphorus, and uric acid. Potassium, of course, very evident as to why it would be dangerous to the patient. You can have hyperkalemic cardiac arrest. And the phosphorus and uric acid, because basically what these two would do is they would, phosphorus would combine with calcium. That's why they'll have low calcium, and that would clog the renal tubules, and the kidneys would back off. And similarly with uric acid. This then leads to decreased renal perfusion, and then further renal vasoconstriction and renal failure. So this is, again, an East of England chart as to how they would monitor these patients, depending on their risk category, their diagnosis, as to how frequently they are monitored with blood tests, etc. And what kind of prophylaxis they would use. So there are two things that we would use: rasburicase or allopurinol. And rasburicase is used more and more commonly nowadays. Hydration, as I said, is the primary treatment modality.
But we don't start rasburicase until we know what the G6PD level is.
Yeah.
So we need a G6PD result.
Yeah.
Before you start rasburicase.
Yeah.
So we often start with allopurinol and switch.
And then switch. Yeah. So hydration is the cornerstone of both prophylaxis and management of tumor lysis. And then the way we would manage is, of course, a pre-treatment weight and then daily weights to see whether we are kind of making them massively positive. Of course, regular bloods and the fluid used is this.
Test critical incident.
So the usual fluid that we would start is dextrose saline without potassium because you're using large volume. Huh? And then sometimes you might want to use less than 5% dextrose and less than 0.9% saline because of the sheer volume. You don't want to get hypoglycemia or hyponatremia purely related to the amount we are giving these children. So if you use any phosphate and urate are normal, they usually start at 2.5 liters per meter square. So if you think about it, the normal maintenance otherwise would be 1.5 liters. So that's still large volume. If there are any signs of tumor lysis, the starting fluid number increases to 3 liters per meter square. And then if the tumor lysis markers are rising further, then depending upon, again, the child and how well they're coping, they could increase the fluids to as much as 5 liters per meter square to control phosphate and urate. But we probably involved around that stage already when they're rising and the numbers are not going in the right direction. And of course, because we are pouring in so much fluid, it's extremely important that we keep a close watch on what is going on and what is coming out. So most of these children would be catheterized. We'd be looking at hourly urine output. And generally avoiding diuretics, but if we want to flush the kidneys out, sometimes we do use furosemide to try and drive the urine output. So this is where I wanted to highlight how the allopurinol and the rasburicase work. So allopurinol basically blocks the xanthine oxidase, so it prevents the formation of uric acid. And what rasburicase does is uric acid urate oxidase, and it basically increases the conversion of uric acid to allantoin, which is 5 times more soluble in the urine, so it gets excreted faster. As Roddy said, rasburicase is only used after we've got a negative G6PD. Although we don't work with a population where G6PD deficiency is common, we would always check it. And word of caution when it comes to asthma, and why we use more rasburicase and allopurinol. So this is about 10 years back when they did a randomized control study when rasburicase was new. And then they showed that rasburicase works more efficiently, reduces the urate levels more quickly in comparison to allopurinol. So it's sort of almost become a standard of care. So allopurinol early on if we don't have the G6PD results back, but rasburicase otherwise. And then, of course, the management of electrolyte disturbances as it comes along, or as we see. When do we dialyze these children? Well, absolute indication is treatment-resistant hyperkalemia, because that's what we worry about the most, really. I mean, having seen a couple of hyperkalemic cardiac arrests, I'm very twitched every time I see hyperkalemia, so I'll fix it very, very quickly. And then when we have very high phosphate levels, of course, the kidneys have completely packed off and patient is anuric, or they have developed pulmonary edema from all the volume we are giving. And then relative indications. Usually, as a rule of thumb, we never dialyze children purely based upon their urea and creatinine numbers. It's always taken in the context of their urine output and the electrolyte levels. So if they have rapidly rising potassium, phosphate, or urate, and we know that the tumor lysis has started and we know we'll not be able to control it, so we would have a lower threshold to dialyze them. And of course, all the other markers of fluid retention with oliguria, hypertension, peripheral edema. So this was the child I was talking about who came to us, and 3 years old, massive abdominal distension, had a large neuroblastoma and ureteric obstruction. So as you see, even before any kind of treatment was started, this child's urea creatinine are not normal, and they have raised phosphate, right? So although respirase has started, their urate is already quite high, and this is where we are discussing whether or not the child should go to theatre so that they release the obstruction, and maybe once the obstruction is released, the kidneys would just work. But clearly this is an indication that there is some degree of tumor lysis going on, right? If there was just a slight increase in urea creatinine because of the external obstruction, then they should not have had this. So then we made a decision to filter this child and stabilize them before they went to theatre for any kind of intervention. You can see that the potassium is already 6.4, 6.8. And this is where, after respirase, see the uric acid has come down fairly rapidly. But what is a good indicator in that setting is the phosphate levels. And then we filtered this for 3 days, and this is where we stopped the filter. But see, very rapidly the phosphate levels go up further, although we've managed to control the uric acid with respirase and hydration. And then we reinstitute filter, and this is when we again stop it after 72 hours, and then the electrolytes held, and that's when at that point she went to theatre to have ureteric stent, and then further chemotherapy and possibly a second surgery later on once the tumor has shrunk. So the numbers were actually quite telling if you look at this chart for this child. So those were the two main areas which I wanted to highlight when it came to oncology, and I'm probably now just going to very quickly skip through some of these slides to say this is what we would see, maybe more rarely, and Roddy will remember this child. We recently published this as a case report in BMJ. The mediastinal tumors. This was a little girl who presented with stridor to the GP. The GP gave steroids, went home, but the stridor persisted, came and got admitted, and somebody did a chest x-ray and saw mediastinal mass. She was then transferred here, and Roddy put in a PICC line while she was being held by her mom, which went all fine. And we were still trying to debate how best to move her diagnostics as well as treatment further. Then she developed a viral infection and had a near cardiac arrest, respiratory arrest really. So she was tubed, and then we couldn't ventilate her because the tube won't go further beyond the mass because the trachea was all compressed. And it sort of became a one-way valve where we could only push air into her lungs. So she became massively hyperinflated, but there was nothing coming out. And then we changed the tube over a bougie and put an armored tube, which is probably a bit stiffer because of the metal reinforcement. And then we were very anxious in terms of whether or not we would cause damage with the armored tubes, because generally speaking, we would not ventilate anyone with an armored tube beyond 12-24 hours. It's something which is used in theaters, specifically in surgeries that require patients to go prone because they don't kink very easily. And then if a child needs to come back to us post-theater intubated, then usually the anesthetist would change the tube to normal tube because we are worried that that stiffness in itself could cause some degree of tracheomatosis. But this child was ventilated with an armored tube for a week. And then she did do quite well, actually. And she's undergoing her treatment and the tumor is shrinking. So rare, but scary, probably the scariest amongst all the kind of oncological things we would see on PICU, because sometimes even if you've managed to get a tube in, the mediastinal mass would be compressing beyond where your tube is going. And despite that, you'll not be able to manage these children. And the only way in that setting would be to put the child on bypass whilst there is some kind of a treatment, either surgical or chemotherapy, steroids that would shrink the tumor. So most commonly, anterior mediastinal tumors are non-Hodgkin's or Hodgkin's, rarely teratomas. we actually saw a teratoma, which was an asthmatic girl, 15-year-old, not really an asthmatic. She was diagnosed as an asthma by her GP on the phone. This was in the midst of the pandemic, and took salbutamol on and off over a period of 6 to 8 months. And then she had what was described as, she became breathless, took nearly one whole inhaler of salbutamol over a period of an hour, and then had a cardiac arrest. The pre-hospital team went and did bilateral thoracostomies, came into ED, had some output, and then lost the output again. And then the anesthetist felt that they had lost the tube. So they said, we've lost the end-tidal race. So they took the tube out, and then they couldn't intubate. And then by then the CPR was already quite prolonged, and and then the decision was made to go for a front of neck access because we couldn't ventilate her. We refingered her thoracostomies to see if she had reaccumulated. And basically, as soon as the neck was made for a front of neck tracheostomy, and by this time it was 7, I was here. So the ENT registrar came, and she just bled. There was just fountain of blood. I thought they had nicked a carotid or something else. Unfortunately, on postmortem, turned out that she had a teratoma, highly vascular, yes. But she was somebody who had never had a chest X-ray, or possibly not, was not, like, fully examined physically. So that reminded me of my first lesson in pediatrics. First presentation of asthma should always have a chest X-ray, because you never know what you're missing dealing with. The middle mediastinal can sometimes be lymphoma, and posterior is neuroblastoma. And why we worry about it is, of course, the airway compression is life-threatening. And sometimes they can have heart and great vessel obstruction. SVC obstruction is not uncommon. And that child did have SVC obstruction, the one that I've just spoken about. So where are we involved as the PICU team? Well, evaluation, I think we go more frequently downstairs to C2 to look at a child who's got a mediastinal mass, mainly to look at their stridor, look at whether we need to bring them up to PICU, what can we offer, whether they are safe to lie down, whether they are safe for having a CT scan, etc., and whether or not they'd be safe for anesthesia. So the bottom line is we leave them alone as long as we can, without any intervention, because anything could cause a complete compression, and any kind of distress in this child can make that airway tone, which is holding the airway open, go completely. And if we can, then we could do a CT scan, which clearly defines the anatomy better. We can distinguish at what level the obstruction is, what would be safe or not, but that's clearly not possible in smaller children. So as I said, we try to leave them alone. So this particular child was transferred by Panda in a sitting position. Roddy did a PICC line in sitting position. So we sort of just left her in that situation. She slept sitting up in her mom's arms. And then if that is not working, which is what we tried after she was intubated, is to try and lift the mass off the airway. So we put her in left lateral position, but clearly didn't work for her. If we are in a situation to put an IV access, preferable is lower extremities, specifically if there are any signs of SVC obstruction. And then, of course, all these have to be put in the context of what the child is like. As I said, the primary motive is to try and reduce any kind of distress. So you don't want to put on face mask or any kind of non-invasive mask if the child becomes more distressed, because that will make the airway obstruction much worse. And then, of course, avoiding sedation, because we can be dealing with an extremely complex situation. So when this child was in that day, we were already talking to ECMO team and thinking about whether we would need to pressure onto ECMO and have a mobile ECMO team come here. And if the child has impending respiratory failure and intubation is required, preferably in theatre, if we have time to move the child to theatre. Awake clearly is not an option for a young child, but could be considered in expert hands in an adolescent, maybe, because you could do a bronchoscopic intubation, which probably would preserve the airway tone for longer than a child who's sedated. Of course, the recommendation would be to have cardiopulmonary bypass available. We don't have the luxury of that here in Addenbrooke's. And neuromuscular blockade is always a question mark. Again, that little tone, as I said, might be enough to keep the airway open. And once you get that, you could lose it. But equally, you're doing a complex intubation, and what you don't want is to not have a optimized child and then not be able to intubate because the child's not paralyzed. And then we do give a big dose of steroid to these children, which can have its own problems, but then we are dealing with an emergency situation. We want to save life, so we don't care whether we would miss the diagnosis or if the tumor somehow lyses, we can deal with that complication. So it's less of an issue. And then we've got brain tumor emergency. So majority of, again, the children we would see here on PICU RHDU admissions post a tumor debug. What is it?
It's just
Who's that?
Very.
But the common ones that we would see are hemorrhage and present with signs of raised intracranial pressure, sometimes peritubular, peritumor brain edema, and the way to treat that would be using high-dose steroids and then waiting for surgeons to take them to theatre if it's amenable. Hydrocephalus, of course, is probably, I should have come the first. It's the most common tumor emergency that we would see in pediatrics. There's somebody knocking at the door.
Hey.
So it's common with posterior fossa or midline supratentorial tumors, and basically just a acute presentation in a child who's been complaining of headaches for a couple of weeks or days, or has got some kind of blurring of vision, and then they suddenly collapse and you find that they've got a massive tumor in obstructive hydrocephalus. Seizures, of course, is common. And then more infrequently, chemotherapy or drug-related neurological complications. I thought it was worth mentioning this because we've seen a few patients. So the posterior reversible encephalopathy syndrome, which may not be entirely posterior as highlighted by the MRI scan. But essentially, cytotoxic drugs are implicated and steroids are implicated. And these are the major group of children who would get these. And basically what happens is that something triggers a response by the brain where it stops autoregulating very well. And the response is triggered by severe hypertension, and that leads to vasogenic edema. And majority are fully reversible, but there are a few who would be left with some kind of long-term sequelae of that. And that's where the question starts, because it's not the easiest diagnosis to make, especially on CT scan, as majority of changes are posterior. So you need an MRI, and an emergency, whether or not you would have time to do an MRI, is controversial. And in that situation, whether you're treating hypertension as the potential cause of encephalopathy, or whether you feel the hypertension is body's response to keep the brain perfusion going. So that complexity exists. But we've seen 3 or 4 children with press in the last 1 year, which is slightly more than what we have in the past. So just something to be aware of. And then spinal cord compression, again, extremely rare in pediatrics, only in 3 to 5% of children with cancer, mainly neuroblastomas, sarcomas, or Hodgkin's disease. Veno-occlusive disease, something we don't see here because we don't have bone marrow transplant, but this is something that happens usually with certain kind of induction regimes used for pre-bone marrow transplant chemotherapy, and leads to damage to the sinusides, hepatic sinusides, and leads to a complex hepatorenal syndrome with ascites, jaundice, thrombocytopenia. These children can be fairly sick, but usually with a careful management of fluids and defibrotide, they recover. And I think they have changed the regimes they use for pre-bone marrow transplant induction. So probably I'm saying it anecdotally because I haven't worked in a bone marrow transplant center for 10 years now. So I think that probably covers most of it. So just to say, we do see a broad variety of critical illnesses related, and there's always something weird and extremely rare, which we would see every year, once or twice. But the good news is long-term survival of many cancers are improving, and the ICU outcomes from this patient group is improving with good ICU care